I would not expect a patient to be satisfied in the 10, 20, 30, 40% range of improvement. Is it better? Well, technically it is better. If you break down that sentence, is better better than not better? Yes, it is, okay? But it's not enough just to make it incrementally better. We're looking for a life-changing, quality of life-changing improvement with the laser. I would not be happy in this range here. Welcome back to the Masterclass for Eye Doctors in the management and treatment of clinically significant vitreous opacities, also known as eye floaters. I'm Dr. James Johnson, also known as the Floater Doctor. So today I want to talk about the stepped approach to the management of eye floaters. And I guess the analogy might be where you might have some chronic pain or an orthopedic problem or many other medical problems. You don't jump right into surgery. Oftentimes the approach will be to try the least aggressive, least invasive, most convenient approach first. So let's create a virtual step here. We'll say the ground level is by far the most common way that floaters are managed worldwide, regardless of your socioeconomic level, your access to medical care, whether you're first world, developing world, and this is historical as well. By far the most common way that floaters are managed is to do nothing. That is, the patient does the examination, the doctor does the examination, rules out any retinal hole, tear, detachment, any other eye disease that might be eye health threatening. And then the usual platitudes are, I recommend you just get used to it. Your brain will get used to it. Do nothing. The fix is worse than the problem. I have floaters. I just ignore mine as well. These statements resonate with a lot of the patients here. So on the ground level is to do nothing. All right. Now, unlike other conditions like infection, inflammation, cancer, progressive arthritis, with floaters, as long as you've ruled out an eye health problem, you don't really have to do anything. If the patient had some peripheral flashes of light, some new onset floaters, and they go to the doctor, and the doctor says, well, you had a vitreous detachment, everything looks fine, you don't have to do anything about it. If it's not really bothering the patient, that's fine. You don't have to do anything. And there are many people who do kind of dodge the bullet. In other words, they do have something like a vitreous detachment or maybe some little squiggles or some thready little fibers. And they're not all that bothered by them. So fine, leave them alone. You don't have to do anything. There's no imperative to do anything. But like I said, by the time that people are coming to me, they're coming to me because they can't adapt to them and they haven't gone away and their brain hasn't gotten used to them. Okay, so the next step for those where it is appropriate would be the low-dose atropine. Sorry about the squeaks. LDA, low-dose atropine. Now, I offer this through my practice. It is taking commercially available 1% atropine, which, if you're a physician, this is a powerful, full-strength dilating agent that at 1% commercially available, it will have you dilated for 7 to 14 days. We don't want that. If it's diluted appropriately, 1/100th, 1/200th of that dose, what you get is a milder dilation that lasts about 24 hours. We're trying to find that sweet spot. For the ideal patient, for those that are typically younger, and they will typically have some very thin, thready little fibers or strands closer to the retina there, which are very bothersome, by the way, they are not candidates for the laser treatment. They're not candidates, really, for the vitrectomy. So for the first, 14 of the 18 years I've been doing this, I didn't have anything to offer them as well. So the low-dose atropine, by dilating the pupil ever so slightly, it diminishes the shadows that we see as floaters. I'll talk about the optics of floaters in another episode and go into more detail there. But for that younger person, the low-dose atropine has been a fantastic addition to my practice. I mean, to be able to offer at least something. Is it definitive? Does it destroy the floaters? Does it even answer the questions as to why they have floaters? No, it doesn't do any of that. But it empowers them to dial it down significantly, and in some cases, dramatically. And a lot of my 5-star reviews on Yelp and Google in the last few years have been younger patients who've just showed such extreme gratitude and appreciation that at least it's something. All right, so next step up would be the laser. That's a pretty big jump up. So the laser. Now this is what I do. This is where I have made my reputation. This is what I've been doing pretty exclusively for 18 years. Not everybody's a candidate. I just mentioned that 20 and 30-year-old patient with those small, wispy little floaters are generally not going to be a candidate because their floaters are almost always too close to the retina. But for that over 40-ish, 50s, 60s plus, especially if they've had a posterior vitreous detachment, they have a Weiss ring, they have large cloudy floaters, they have membranes, everything that has kind of moved into that middle part of the eye, that's a group that I treat. And it's all over the place as far as expectations. I'll talk about that in just a second here. But that's my bread and butter. That's what I've done for 18 years. It's hard. It's difficult. This whole series is going to be very, very much focused on laser treatment for eye floaters. Now, let's say somebody comes into me with asteroid hyalosis, which, for those who don't know, they'll have hundreds, tens, if not hundreds of thousands of these microscopic little calcium phosphate phospholipid crystals. They're not treatable with the laser. And I'll take a look at that person. I'm saying, I'm not even going to try the laser. You should get a vitrectomy. If this is bothering you and it's not going to get better on its own, a vitrectomy is the way to go. And it's a cure, it's definitive, it's amazing. So right out of the gate, I'll recommend a vitrectomy. Or it might be a situation where we've done 1 or 2 treatments and just can't get traction. 1 or 2 treatments and it's 10, 20% better. Well, that's not life-changingly better. I can't justify more treatment. I can't even justify my fees at that 10 or 20% better. So sometimes it might be after 1 or 2 treatments where I just concede that I might have the wrong tool for your problem. Or the analogy I use is I say, my laser is a flathead screwdriver. You have a Phillips head screw. I might be able to turn that screw a little bit, but as soon as I start meeting resistance, I just can't drive that screw home. So it might take a trial treatment or two to determine that this might not just be the right application. And it might be a situation, jumping up into that vitrectomy, where somebody has had pretty good results with the laser. 70+%, 80+%. And many people would say, well, I'd be delighted with that. And most people will. But some people, that last 20% is still really, really bothersome. And although they're very appreciative, they're like, thank you, Dr. Johnson, it is better. And then every once in a while, I'll get a message by email or indirectly somehow where they'll tell me that they went ahead and had a vitrectomy and they're delighted and it's been great and they're super, super happy with that. And I'm like, good for you. That doesn't hurt my feelings. I don't see that as a professional failure. Everything is a stepped and staged approach. Let me draw something different here to kind of maybe sort of explain the expectations of those treatments as well. So I'm going to draw a range. And this range goes from 0% to 100% better. And this would be the patient's subjective perception of improvement after some sort of treatment or intervention. Okay? In other words, you do something, you manage those floaters, and you ask the patient, what general percentage of improvement would you say that we've accomplished with these various interventions? And I think that there are sort of stereotypical and expected ranges of expectations. The first step, or the ground floor course, was do nothing. That has the lowest likelihood of getting significant improvement. Now I'm going to draw that curve or that range of expectation way, way out there. And the reason is because some patients who have maybe some of these smaller floaters like I drew here, if that was just to move a few millimeters away from the retina, you wouldn't see the shadows. And because you don't see the floaters, you are aware of the shadows that are being cast onto the retina, and small, thin, wispy floaters a little bit further away from the retina will be greatly diminished or not seen very well. I've had some people, for instance, sitting in my exam chair, and their spouse or partner sitting in the other chair says, oh, I had floaters when I was younger. They just went away. And so I'll say, for the most part, doing nothing is weighted very heavily towards really no improvement or worsening. And maybe asymptotically, way, way out here, there might be some people that kind of get lucky over time. It's very, very hard to predict. You never know. But there is some hope and optimism for those that aren't really treatable with more intervention, that it might get better on its own over time. Hard to predict. The low-dose atropine, for the ideal patient, younger, thin, wispy fibers and nests of floaters that are closer to the retina, some of those people are getting really, really good results. Very happy, and I'm happy with that as well. They are saying it is essentially, I'm not seeing them, maybe just under bright light or certain conditions, I'm seeing some of them, but greatly reduced, 70, 80, 90, 95% reduced for the right population. Now, the people who are older and they've had more comprehensive changes, big membrane peeling away, larger white strings, large clouds, that mild dilation of the pupil is just not going to have that effect. So that would explain this group out here. So when somebody contacts me interested in a low-dose atropine and they're in their 50s or 60s, I'll say, there's no harm in trying. The optical principles are more or less the same. There is some possibility and some improvement, and we could try. But I do mitigate those expectations. For the younger patients, the expectations are much higher. Now, what about the laser? No, let's jump ahead. The vitrectomy. The vitrectomy has the greatest expectation of significant improvement, if not an outright cure. And that is awesome. Amazing. So why are we messing with this other stuff? Why don't we just jump right in and say, you know what? You've got floaters. Let's do a vitrectomy. I don't do them, but we could send you to somebody who does a vitrectomy. Well, I listen to my patients, and the vast majority of my patients, and maybe it's just selection bias, but the vast majority of my patients come to me and they're like, oh, I'm aware of the vitrectomy. I've watched the videos. I've read through the forums. I do not want a vitrectomy. I'll try the laser, but I'm not going to a vitrectomy. I get it. I understand it. It has in medicine, we call it the icky factor. It is icky. It repels people. Now, I don't come out of the gate demonizing and vilifying the vitrectomy. I like to keep it as a recommendation. I keep it in my back pocket, and every once in a while I'll say, maybe you need the vitrectomy. And so I will keep it as an option. And sometimes, so in other words, I don't want to paint myself into a corner telling people the vitrectomy is horrible. I don't look at the vitrectomy as my direct competitor. I look at it as further down that spectrum, or further up that stepped approach. We can try this. If we can get it better or good enough better with the laser, great. And if we don't have to do the vitrectomy, great. But there is this other thing. And regarding the laser, there's nothing that I would do with the laser that would preclude or prevent somebody from pursuing a vitrectomy later on. So we're not at a binary decision node, laser or vitrectomy. We're at that stepped approach or working along that spectrum. So the problem with the vitrectomy, particularly with younger people, is, or I should say particularly for people that have not had a PVD and have not had cataract surgery, is there's a very high likelihood that it will cause cataracts. That kind of sucks. By removing all of the vitreous, all of the proteins, all of the antioxidants, you get more oxidative stress to the lens, and many doctors will say, regardless of the technique you use, which gauge and needle you vitrector you use, which limited whatever, there's going to be a higher rate of cataracts. And now if that 25-year-old now develops cataracts, they're going to have cataract surgery, which is going to remove their natural lens's own natural accommodative ability, so it's kind of messy. And I have some stories I'll tell later where it can go really messy, like vision loss kind of messy. So I pretty much come out of the gate telling younger people, I'll see you if you really want the examination. Of course, I'll see you, but it's complicated. Now, the laser. So we have this 0 to 100% range here. The laser can conceivably run the entire gamut there. This is problematic. It's problematic because I would not expect a patient to be satisfied in the 10, 20, 30, 40% range of improvement. Is it better? Well, technically it is better. If you break down that sentence, is better than not better? Yes, it is, okay? But it's not enough just to make it incrementally better. We're looking for a life-changing, quality of life-changing improvement with the laser. I would not be happy in this range here. My goal is to get that person over the hump, whatever that is, 40, 50, 60% better, over the hump after a first treatment. Usually I can do that. If, for instance, I do a treatment and it's complicated, there's stuff all over the place, and they come back the next day and they're like, yeah, no, it's really not that much better. Then I have to have the talk, which might include part of the conversation that says, if that first treatment was pretty aggressive, like what expectation do I or we have that a second treatment is going to make that significantly better? Are we going to go from 10% now to 80%? Not likely. We may be looking at very small incremental improvements, and that's just a lot of money to spend and a lot of coming back and a lot of travel to just get small incremental improvements. So sometimes if I'm not sure what I've accomplished with that first treatment, I'll be like, don't pay me yet. You're coming back tomorrow. Let's have that conversation. Let's see what we've accomplished. And if we're significantly better, well, then that's a pretty good predictor that more treatment will make it even better. And so we're on the road to that. Now, I cannot compete. I cannot generally get in this range here with the laser. But I've found that if I can get significantly better, this would be, a lot better. Good enough better. These are not real acronyms. To the point where patient says, "Oh, this is a lot better. This I can live with. At the end of the day, I'm not really bothered by my floaters. This is good. I'm glad I did this. And I don't have to do the vitrectomy." In one of my episodes that will be forthcoming is the mission statement, which says, the last bullet point is, "And I'm in the vitrectomy avoidance business. My goal is to get them good enough better, a lot better. This I can live with kind of better without having to consider the vitrectomy." And usually I can do that. So that's really kind of it in a nutshell. It's a very simple stepped approach. It makes sense to me, and it's not perfect, but if you're managing people's expectations appropriately, always manage expectations, remanage those expectations. And I have the privilege of spending a lot of time with my patients. I'll spend about an hour and a half or longer, even at that first consultation. A lot of that is education, managing expectations, remanaging those expectations. I think that's really important to develop that sense of rapport and trust. And people, I think, are forgiving of imperfection. Low efficiency treatments is a form of imperfection, but they're forgiving of that if you're treating them fairly, and I try my best to do that. So that's my stepped approach to treating floaters. I don't do vitrectomies. If somebody does need a vitrectomy, I will send them out to a retina specialist to do that. I hope this helps. It's a really very simple approach, but sometimes it's just nice to kind of describe that. What I internalize is just force myself to put that on the whiteboard here and try to make sense of that. I have lots of episodes of management and treatment of floaters in mind. I've got a wall full of Post-it notes with ideas, and this is just an ongoing kind of endless process. If you find this helpful and you think you want to watch more of these, you can subscribe. That will help other people find me, of course. You can hit the notifications bell. That will notify you when I upload another one. If you are a physician particularly, and you are either treating floaters or interested and curious, you're floater treatment curious, and you have either particular questions or you have hints or tips or tricks that you can share, let's make it collaborative. Let's make it a little society and try to improve the process for your comfort, the quality of the treatment, and more importantly, the quality that the patient receives with that treatment. So thank you for watching, and it's been a pleasure, and until next time, have a great day.